So the impact is every year, not all the candidates will make it. And based on the data analysis by the All India PG entrance examination which we conduct, there is a ratio of 1:6. That is, for every one candidate who will make it in the competitive exam, there will be 6 who will not get any seat.
Sure.
So with this, there is a cascading effect, and candidates today, the 3rd year, 4th year itself, they put less emphasis on the curriculum and more on the MCQ techniques, and the whole of internship today they are absorbing and preparing for the entrance examinations rather than deploying that internship for their skill enhancement as well as practicing the knowledge which they have learned in a manner of supervised practice under guidance of their teachers.
So for example, I have done my MBBS. Okay. Now I am appearing for my exam. The exam can be maybe within 2 weeks of final MBBS. Right. That can be one answer. Right. Before internship, right, you take the exam. Why take an exam after internship?
Right.
So that the exam can be taken before internship. That's one. 2 is those who have failed. Those who have failed, if they join a residency. Right. If they join a residency, suppose they join for 1 year residency, that can be converted into a 1 year diploma in family medicine.
Exactly.
So that they instead of sitting at home and studying,
right,
they can be a part of the study,
right,
and they end up into a diploma. Plus, at least they are clinically utilizable.
Exactly. They are part of the healthcare system, rather than being underutilized or non-utilized by the healthcare system. And both of these suggestions, actually rescheduling the entrance examination to a position where this entrance examination for PG could be placed in the first quarter of internship, that is immediately after their final MBBS. So this proposal was discussed at the highest level. That is, when I say the highest level, it is the Ministry of Health and Family Welfare informally, and both the Medical Council of India and the National Board informally made their submissions, and hopefully this dialogue should be continued further, and we need to take this dialogue to the stakeholders, especially our medical colleges and the young graduates, of how they would take it. The other side of this aspect is from the candidate side. Today the final prof of MBBS is one of the toughest medical of all the 4 profs which the candidate has to appear. So appearing in an examination within 3 months, it has its advantages also, little disadvantage of the candidate's fatigue being there.
But it will be the same for everyone.
But it will be same for everybody. Exactly. Exactly.
It should be better. In fact, it should be better. I have been blogging, you see, and studying for almost 1 year. And now everything is fresh in my mind. If I have to appear in the exam, it is much better. I know it.
But then there is a difference in the system of exam. No? That's all the theoretical exam. This is all MCQ. And the type of questions that come in that entrance exam,
then they will start studying like that in MBBS also.
Exactly.
Yeah, that's the issue.
Their preparation will.
Because theory also will have. They will also have a theory and
Basic,
In any way, in your DNB exam, there is no practical. When it is a theoretical exam, then why wait for 1 year?
Absolutely.
It should be done.
Yeah.
And then second, my question second is, why can't MCI and DNB exam be one single exam? That you can choose whether I want a PG or I want a DNB. What is happening today is that a person will get both the seats, then he will lose one of them.
Yeah.
Why? Let it be a common
A lot of
exam.
people are doing doubling. People will
That's what I'm
come with
saying.
MD and DNB both in the same subject also.
No, they can do it later on.
Later.
Once they do a MD,
Not
then they can do a
concurrently.
DNB, not concurrently. I'm trying to say, why can't there be a thinking that both the departments have a common exam? Let people choose whatever they want to
Plus,
do.
why should there be 2 degrees? Where is the need? That means the seat which is being occupied by a person who has already done an MD and now he is appearing in the DNB examination. That means somebody else is losing that seat, no? Somebody else is
But
losing that seat.
that's the question. Why, did the government think of starting DNB when MCI is already doing its job in medical colleges and other places for postgraduates?
See, the DNB stream of education is to tap the surplus capacity or the available capacity available in the non-formal stream as such. And secondly, to set standards in medical education. So today, it's a global phenomenon that medical education is happening where the profession is there outside the medical colleges. In fact, in the DNB stream today, we are working only with large-scale hospitals in the government and public sector. There is a widespread move worldwide. If we see the model of the American boards and the Royal Colleges, they are taking up training where the practitioners are. In fact, most of the GPs or the large GP practices in Australia and UK are being used to train GPs under the NHS system by the Royal College of General Practitioners.
Before I go further, there is a Kamlesh Kanodia who says if interns are not attending to hospital duties, then how are they getting internship completion certificate? Then another one is, he has not written his name. We need to change the mindset of students at MBBS level. They should go for clinical rounds at that stage itself in second year so as to correlate cases with reports and become clinically oriented to subjects like microbiology and pharmacology. Right. We need clinical microbiologists and not technical microbiologists. Right. And is it possible to orient the student at that level? Is microbiology reporting being done by pathologists in many private hospitals justifiable? What actions can be taken in such situations? They're asking something different as a regulation, but there's one more question which has come is, sir, I am doing DNB general surgery in West Bengal. After completion of my training, if I want to practice in my own state, should I have my state medical council registration? Yes, you will require a state medical. You will require a registration in any state and then you can practice anywhere in India. If so, my doubt is one surgeon who is practicing in Mumbai may come and do the surgery in Hyderabad at some corporate hospital. Probably he might not have AP Medical Council registration, then how he is allowed to do the surgery? See, this is a matter which is under the court, and IMA has a very clear-cut stand that once you are registered with one council, you can practice anywhere in the country. But many states are not allowing that. For example, Delhi, Karnataka, Maharashtra, it is compulsory to get registered with the state medical council. But the Indian Medical Council Act clearly says that you are not required to get registered with multiple registrations. Let the court decide, then the answer will come back as far as this is concerned. So we go back to our DNB. See, how many DNB are getting passed, appearing and getting passed every year?
Today we have an enrollment of 5,400 and roughly 3,500 are passing out of the system every year.
Why only 5,400? Why can't every district, why can't every doctor in the country be given an entry to the DNB program? Let him fail. It's something like ECF, it's something like your foreign graduate examination. Everybody appears and they only pass if they are.
Right.
Why can't I increase this number? Why is this only 5,400?
Right. Let me address this. There are two models by which we can impart PG training. One is an absolutely open model and which is prevalent the world over. The Royal Colleges of Australia, UK, and in America, the American board system. They do not have a very widespread recognition mechanism that this hospital will have this much number of seats. Anybody can go and work over there. And then the colleges, specialty colleges which conduct the examination, they set up a criteria that the Dr. X should have worked for 3 years in the subject of pediatrics at any place, and then he appears in the exam, which is entirely competency based. So that one examination, which is of course structured in various parts, is the kind of specialty certifying examination and gives them the license to be called a specialist. Whereas in our system, we are following a very closed mechanism that we identify the training site, we restrict the number of seats by defined regulations, defined criteria, and that is how the growth in the number of seats or the number of positions which we can offer to the young graduates today is very, very limited, whether it's the university-based system under the MCI or the national board system. And together we are only creating 24,000 seats per annum, which is very, very less compared to the large need for specialists in the country. In fact, if we were talking a little while ago about the shortage of doctors, the shortage of doctors is more at the specialist level than at the MBBS or the basic graduate level.
I'll give you one more alternative, that all those people who are, let there be a special DNB 1-year course called DNB in rural medicine and rural surgery.
Right.
Okay, and let that be only in primary PHCs.
Right. Absolutely.
Let them at least work for a year.
Right.
And then for the next 6 months, they can come back in your recognized hospital.
Right.
So it will be a 1.5 year course or a 2 years course. 1 year they will have to work in a rural area. And then they appear in the exam and they can be given a separate program called diploma or fellowship, whatever you want to call the rural medicine and surgery. What will happen with that is they will end up into getting a seat, number one.
Exactly.
And two is all those people who are waiting for exam, 1 lakh people who are waiting for exam, they end up in getting one extra degree.
We implemented a pilot of this in year 2007. It's been 8 years that the project remained at pilot stage only. We introduced a program called DNB Rural Surgery. And the way we introduced this program was there was a primary site which was a secondary hospital, whether it is a district hospital owned by the state government or it could be any charitable or voluntary hospital, especially in the district level. And we preferred that the district could be a remote or a far off district. And then this district hospital had to adopt a primary site, which is a kind of primary health center, so an outreach facility. And the candidate was required to spend roughly 1 equal time between both the sites in a structured manner. And his supervision was to be undertaken by the team of faculty. And this trainee had to undergo training in various competencies covering basic orthopedic surgeries, basic general surgery, basic obstetrical gynecological procedures, basic urological procedures. Because today 70% of India's population does not have access to surgical care at all. So these DNB rural surgery program was designed to create multifaceted surgeons, and there are very many international models based on which this program was launched. And if this model could be replicated in many hospitals, firstly,
why did it fail? Is it failing or is it still continuing?
It's still continuing. Wherever we started, it's continuing. We are continuing this program with 6 seats at the moment. And
which is peanuts.
Which is peanuts actually. Actually,
why surgery? Why not rural medicine? And why not all rural medicine and rural surgery?
Exactly. Now, on the medicine side, our family medicine program is structured like this. We are planning some basic intervention in the family medicine program, and we would like to take part of the family medicine program in the community settings. Like in phase 1, we converted 25% of the training as out of hospital. Earlier, all 36 months or 3 years used to be spent in hospital. Today we have mandated 25% of this training will be in that primary settings or the community owned by the hospital. And gradually we wish to increase this and ensure that the majority of the training is in community settings where they work closely with the community. And again, this is
when you're going to use the word rural medicine or the rural surgery, probably it would be better to use it as a community surgery.
Exactly.
The whole program, and people, and then 6 seats in India is...
So the pilot has been very successful. In India, there is a lot of fascination of our doctors to link their job prospects with the government sector. And today, if government sector is able to create even small number of jobs for such specialists, so today these graduates of innovative programs, they found themselves out of connect with the recruitment rules of various state governments. So if we have the governments recognizing such specialists into their system, will attract a lot more talent. And of course, if the government is state governments are able to open up the gateways of the district hospitals for such programs, these programs will take off at a much faster pace.
But do you think, it's still in a lethargic status of the whole system, especially DNB?
No, see, DNB has been pretty aggressive in the last 5 years, and if you see the way we have undertaken quality improvisation in very many programs, today our graduates have a much fair and high chance of passing out in first attempt itself. As I said, the numbers are rising, and we have a contingent of 3,500 specialists passing out every year.
But that's only 60% as compared to almost 90% in MD and MA.
That is we have a very well structured and quality based examination which has not been compromised at any level. So we will continue with the same standards of examination, but try to improve the quality of training as well as ensure that the curriculum implementation is taken up at a much more deeper level so that we are able to improve these standards.
Shouldn't the entrance exam for the postgraduates be oriented on the skills and knowledge which the doctors may need during their practice, right, instead of testing the routine learning and memorizing capacities?
Right.
And there is another, we'll talk about it, and then we have more questions on people are definitely.
Right, let me address this important issue about the skills part being tested in the entrance examinations. This is a very important aspect, and gradually we have been building up skills-based questions, especially the analytical skills, interpretation skills, then diagnostic skills, clinical reasoning into our MCQs. And 2 years ago, we introduced image-based questions wherein ECG spots or X-ray films were being shown to the candidates, and in the examination, and questions were built around that. One of the purposes of introducing computer-based tests in the entrance exam.
Yes, I joined a DNB program. Okay, this is my first day of joining a DNB program. So I'm going to be in the program for the next so many years to pass. How do I pass? What should I do? How? Give me a guidance, because when I join a private hospital, it may not be a teaching hospital, it may not be a teaching structure. So what are the guidelines that a student should behave? What should he do that he becomes a good student at par with any other MD?
Right. See, firstly, whether it's an MD student or DNB student, the message would remain the same for both of them. The only differentiating factor is in MD, the factors in the exit examination are structured to push the candidates on the other side of the passing line. Whereas in the DNB system, the candidate has to prepare his sprint run accordingly that he is able to pass that line. As far as the role of a resident is concerned, whether it is MD or DNB, the entire residency program is structured on 3 fundamental pillars. One is the clinical services or patient care in all the clinical disciplines. Second is the component of research. Thesis writing is mandatory as part of DNB and MD. And thirdly, the academic component. There are academic milestones associated both in the MD as well as DNB program. In DNB program, the academic milestones are very stringent. In our program, the attendance is 100%. Other than the stipulated leaves, which may be the gazetted holidays, a candidate is supposed to be on duty all the days. Whereas in MD program, the attendance required is 80% in the residency program. So today, the clinical care in most of the busy public sector or private sector hospitals consumes large part of the time and energy of the candidates, that they are left with little time to spend on their thesis and the academic component. So my suggestion.
So therefore, always a DNB student, a DNB fail. See, a DNB final fail medicine may be a better skilled doctor,
yes,
than a MD pass student.
Absolutely.
In terms of skills.
Absolutely.
Theory, he will be stronger, because all the time he is studying the story, but he is not spending that much time in the skill. But the DNB fail, because I have seen all my people in my own hospital who have failed, and they are one of the best skilled doctors in various hospitals. They are the charges of.
Absolutely. See, the way clinical medicine is learned, actually there's a new concept in literature which we see more often now, the entrustable professional activity. So out of the large skill sets, what is the professional activity? Say it's doing a procedure in the lumbar spine, and spinal aspiration has to be done, or a liver abscess has to be drained. So all these things are first when a resident comes in, will do as a under the supervision, then he will assist, and finally the skill will be at that level that he will be able to do independently. And in our system, the entire system is built up in a structured manner, and that entrustable activity of that small procedures is being transferred on to the candidates, because they are working where the action is, and they are spending more time on that pillar of clinical service delivery. So that
I again come back. Suppose I'm joining a DNB today. So what are the ways? A, in my own institution, there is a teaching program. B, is there any structured DNB teaching program? B, C, are there other programs by DNB who they allow in a year that you can go for 48 hours and learn these things, which is not available in MD?
Okay, let me address this part of how they can do. So this utilization of 36 months is very appropriate, has to be appropriately undertaken. And the first and foremost thing the student should rely upon is the curricular document, and they should plan their own agenda of how they would like to cover that curriculum. Because in the DNB examination, closer to the end of their training, they will have a theory examination which is national level, independently assessed, and where nobody can help anybody. It is their own knowledge which they will transcribe on paper, which will help them pass. Secondly, we are having a system of 3 formative tests which are mandatory to be undertaken by all the residents. And these formative tests are undertaken in the middle of first year, middle of second year, and middle of third year respectively. And they are near replica of the final examination. And the whole purpose of these tests is to give them feedback so that they can do the course correction when they are learning. So firstly, they should stick to the curriculum. and they should define which module they have to cover in each month, and they should not miss that deadline. And in medical education, that parlance is called the hidden curriculum, or what the candidate plans for himself, the candidate's self-plan, self-study plan. The institution will follow their own plan, while the institutional plan may vary, may deviate, but candidate's own agenda has to be clear that in 36 months, if there are 3 prescribed textbooks which he has to read, he has to read in 36 months. He can't wait for 48 months to read those textbooks. Second is focus well on the plan and scheme of these formative assessments.
Okay. Are there classes taken by DNB on a regular basis, on the website,
We are supporting central teaching. Besides the institutional teaching, this is taking place at the state level as well as centrally.
So how many in a month?
See, we are running a e-learning program in some of the disciplines. Not all of the disciplines are covered because the total number of discipline is pretty large. And in some of the disciplines, as pediatrics, pediatric cardiology, our programs are taking off regularly, and roughly we make 3 to 4 contacts in a month on the webinar platform with the candidates. In radiology, again, we have launched the webinars, and a similar contact is.
So there is a institutional training and there is also a central training.
Yeah.
Okay. Do you also have a virtual platform where people can go and study on a DNB site, some difficult lectures?
Yeah, we have prepared course videos which are available in the library of all the institutions, although they have not been hosted on web server, but those physical DVDs are mandatory requirement with all the hospitals, and those DVDs actually are designed to cover 2 aspects of curriculum, and they are available in all the disciplines. One is the core things as communication, research methodology, for which central teaching is very, very essential to attain uniformity across the country. And second is difficult areas which are very, for which faculty is very rarely available. So maybe the recent advances, instrumentation, or parts about biophysics. So those parts for which central teaching is the way forward. The content is available, and all that content, subject-wise, it's a compilation of around 800 DVDs, which we have already provided to all the hospitals.
Are you sure you are able to maintain that system so strictly down to that level that in a hospital, in a district, people are following the instructions, number one, and then somebody has asked me that how do you check the quality, how do you maintain the quality, and if somebody is not maintaining the quality, what is the procedure with the student?
Right.
The student has asked me.
Right. Okay. See, for quality, there are 3 pillars in which we have to work on: the input side, the process side, and the output side. While the input, which is the entrance examination, we are controlling, we are the gatekeepers, and so output side, again, through the examination we are maintaining. Now comes the process side. In process side, there are 3 tools with which we are working. One is the renewal is not perpetual. The accreditation renewal is not perpetual, it is periodic. So the periodicity of renewal now as on date is 4 years. So every 4 years the institution has to come back for re-accreditation. And at the time of re-accreditation, we do look into the feedback given by the candidates. And unlike the some of the criteria of accreditation which are quantitative, our criteria focuses on the qualitative aspect also, which is an interaction with the candidates. The existing trainees over there, we always have a closed door one-to-one interaction through our assessors. Then the communication channel of the board is always available. They can give us the feedback. In case of any shortcoming, we immediately react to that. And this may include even stopping the program or relocating the candidates or issuing advisory or...
Can you tell our viewers what is the site or where do these students go when they are trying to complain about any shortcoming in that center?
See, on our website, there is a link called Contact Us, and the entire communication protocol is given there, including the email IDs. And the email ID is a monitored email ID, and each of the email which lands over there is strictly monitored at the highest level. And immediately we have a feedback and a centralized grievance redressal mechanism, which is a digital platform. In that, a reference ID is generated and that file is tracked.
Okay, what I'll do is quickly I'll ask 7 or 8 questions which have come. The first of all is my own question that suppose I pick up family medicine students. Suppose Indian Medical Association wants to create a 2 days course or a 3 days course.
Right.
8 hours into 3 days, 24 hours, that will 48 lectures.
Right.
And suppose I want to teach the whole family medicine.
Right.
So I create 48 lectures, video 10, and 20-minute lecture, 10-minute discussion, 24 lecture, 10-minute discussion. And then I involve all my states, all 30 states, on the same day, on the same 3 days, pan India, 30 such programs going on.
Right.
People register and they update their knowledge.
Right.
Is it possible?
It is possible.
Think of it. B. Those people who pass DNB, after 5 years they will not know what has happened in the last 5 years.
Okay.
So therefore, can there be possibility of associating with IMA that all those who pass, every year there is a refresher course, what is new in that year? I'm talking about compulsory, I'm not mandatory, I'm not talking about options. I'm talking about mandatory, that they attend a program which is standard. So suppose I created 2 hours video, every state branch simultaneously arise, anywhere you can register and attend that program so that you are refreshing your knowledge. Think about it. The question which I have got is, he says, are you satisfied with the level of teaching in non-medical college hospital offering DNB training? Kamlesh Kanodia. Quickly answers.
Yes.
Yes. If training is satisfactory, why success rate in DNB is significantly low as compared to MDMS?
I have already told that the exit. Yeah.
How many DNB candidates have been relocated during last 5 years because institution has unable to maintain standards?
It's a small number. I may not recall the numbers exactly,
But it's not a big number.
It's not a very big number.
Can a person after an MD in one subject do an MD in another subject?
Yes.
No restriction.
No restriction.
Then, shouldn't the entrance exam for the post-graduation be oriented on the skill that has already come? Is microbiology, this has also been done, and now there are a few questions. How to pass a family medicine exam? Is there any book or coaching? That they're talking about, are there private coachings available?
Okay.
Concept of private coaching.
Right. See, I'm not aware of any private coaching happening, and we don't endorse and recommend also.
Why not? In every school, in every college.
Yeah, it is happening, but since we are not aware.
No, why can't DNB, why can't your department recognize, why not even IMA, that there are private coachings available?
See, we are keen to work with well-established national institutions as IMA, and very recently we endorsed the academic program of the Indian Academy of Primary Care and Family Practice, and that is that's an independent association which has come out of the DNB alumni alone. We went through their academic program which they have launched for the
residents. I'm saying it. I'm trying to say coaching we should encourage, whether it is IMA or anybody else, there should be a reason. He says, please do, he says, what is EBB course?
EBB course, I'm not aware.
He says, Kamalapati Krishna Vijayawada Andhra Hospital, please do inspection for the first time. EBB course started hospital, please help the students, sir.
DNB over
Which hospital they are saying?
They're talking about Kamapati Krishna Vijayawada Andhra hospitals.
I'm not aware of the hospital name also. Anyhow, I've noted.
Shri Kumar J. Kollam, how to regulate the mushrooming of low-profile medical colleges and upright in the current stinky system of training in medical colleges. Medical colleges is not the issue today. We are more talking about the DNB.
Yeah.
And who should be complained to about a DNB hospital which do not maintain faculty, including SR and medical officer, and when the hospital forces them to do duty in other departments?
Right. So
you can repeat it.
They can visit the contact us and report such issues. Although on the issue of senior residents, I have an observation now, and that is in fact the voice of the profession today. Nobody wants to be a resident after they have been certified as a specialist. And I think we are in dialogue with various other stakeholders, including the Medical Council and various state universities, that should we retain this title of senior residency? Because even today, established hospitals in a city like Delhi and Bombay are finding it difficult to recruit senior residents at a very high salary. People just want to call themselves as attending consultants or junior consultants, but they don't want the tag of senior residents.
We can't find a single one. You have to call them a junior consultant or a clinical associate.
Yeah.
You see, if I have done medical oncology DNB and I've put in so much work, and then you still call me a resident, it is below my dignity, I refuse to be. So those people have to be enrolled as an assistant, junior consultant. Nobody will join.
No, they prefer to be in government.
I got 5 queries, and all of them are asking, why can't we have a course of 48 to 72 hours on a yearly basis to summarize our, the Harvard has a course,
Right.
1 week's course, the whole medicine is revised.
Right.
Why can't, my question is same for DNB as well as
Right.
MCI. Why can't there be a course which IMA can come or anybody can bring it, a course of 48 hours every year, revisiting the year 2014.
Right.
Everything thing, and these courses should be, see, anybody can bring. I started this concept, did it for 5-6 years, but this has to be participated by the DNB and MCI, so that they recognize that whatever is new in that particular year, somebody is there to tell you. Otherwise, we will be dependent on pharma companies.
Exactly.
And then we get blamed that there is an excess.
I fully agree with you, and it's a very valuable suggestion that well-recognized accredited review and refresher courses are need of the hour, and we as professionals have to do much more to scale up these activities, and we must identify and channelize our energy in partnership, in sync with every institution possible today, and undertake these courses.
Another question is, why do you ask a doctor from one state to appear for a practical examination in another state, and there is a language barrier? And I'll tell you why. Because I did it from Sevagram. I was there for 8.5 years. It took me time to understand Marathi. I had to learn Marathi. And if my exam would have been in Gujarat, so I would not be able to understand the patient.
Right.
Even in Marathi, in 8.5 years, we could not understand how.
I agree. This is a very challenging situation, and there are
or allow interpreters.
no, interpreters are allowed, and then we are giving extra time also, because when an interpreter is involved, conventionally we give around 45 minutes for a case preparation. We have instructed all our coordinator and examiners to allow extra time, and in consultation with the candidates, at how much time they need with the interpreter. I'll just explain, this problem is more of logistics rather than a policy. Even if I was to dilute this policy and say that candidate will remain within the same state, I can't have all the practical centers within the same state. It's a national level examination. For a discipline, I'll have 8 or 10 or 12 centers across the country for that discipline. So some candidate will have to make a move.
I think it's all candidates move out
Yeah.
of that state.
But today what we are doing now is we are trying to keep them within the same language zone. It is candidates who are from the Hindi belt, we will retain them in Hindi belt, and so on.
So I have just to say that you are watching this program on emedinexus.com, also on the eMedinexus app, and also on IMA website. And all your question and answers, you can also interact on your eMedinexus and IMA website, and you can post your questions there, and we will also put the answers permanently there. And this video will also be available later on and you will get frequently links and you can watch. And again, because the time is slowly passing by,
Last question.
you ask your question, but after both of you ask the questions, I want to emphasize in the last 15 minutes. Again, my question is one: how to pass?
Okay.
How to pass means
Not only how to pass, but how are they at par with MD students when they join some government jobs or they apply for it?
Is it
faculty.
DNB and MD same, or it is 3 versus 2 years?
See, the current regulation which is guiding this equivalence, and this issue is only in medical colleges, when they join as faculty.
Yeah.
When they enter into profession, there are no issues, both are specialists. As far as the medical college placements are concerned, the last regulation which is there, that is the TQ 2012, as per that, those who have passed out of medical colleges, which are running the same parallel programs, MDMS programs, or undergraduate programs, they are absolutely same, and no additional research or teaching experience is required.
No, AMD was just passed, and a DNB was just passed. They are equivalent.
They are equivalent, and in case of DNB, if they are passing out from a medical college, there are some medical colleges.
They're from private sector.
From private sector, no. They will have to do 1 year.
1 year. So they are 1 year minus.
Yeah.
They are 1 year.
1 year.
1 year of senior residency they have to do. So
If there are two students for the same post, one is MD, one is DNB, there is only one post.
right.
Do you think MD person will get priority in that?
I think the panel of the interviewers who are assessing the candidate, they'll have to identify who's the best of them based on the parameters for the job. So,
I'll answer your question.
Yeah, sure.
We have DNB people also and DM people also in medical oncology. We find DNB is much better than the DM ones.
Yes.
Much better. This is experience of last 10 years or 15. Now my question is, medical oncology DNB, the hemato-oncology component percentage should be increased. Currently, what percentage are you allowing? The posting in hemato-oncology, when they're doing a medical oncology DNB, what percentage of those 36 months you see, you say they should go to the hemato-oncology or the BMT program?
No, that's a very nice question which you have asked, and I had the opportunity to revisit this issue around 3 months ago, wherein I had two teams debating this issue, and although the hematologists wanted to maintain their professional silo and wanted to create a no barrier zone between the two sides, as part of our curriculum, I would strongly advocate at least a 6 months posting in hematology, because of the peculiar nature of the discipline as such. In fact, in pediatrics, the same program is called as the hemato-oncology program, whereas in adult we are having two different programs.
My other question is, when it comes to the faculty, obviously the hemato-oncologist and the medical oncologist, when you say that for medical oncology the faculty required is this, do you consider the hemato-oncologist as also part of the faculty for the DNB medical oncology, or you don't?
No, right now we are taking them as adjunct faculty, although there has been a suggestion made that we should count the hematologist as the main faculty. But the point which you are evaluating here is it should not come at the expense of a reduction in the existing number of faculty for the medical oncology. So this aspect we are carefully evaluating. It is in this regard that our meeting took place 3 months ago, and I'm sure that we'll be able to find a solution with a wider consultation very shortly.
You see the practical difficulty that we are facing. The DNB medical oncology students, we have a very strong BMT program, very strong BMT program. We have done 50 haploidentical in the last 6 months, which nobody in the world has done. Which nobody in the world has done. Now we need the residents to be over there. 2 consultants cannot do it. Now the DNB residents, when we put them in medical oncology, we post them over there. Within 3 months, they are burnt out. The word is burnt out.
Yeah.
They don't want to enter that because it's a very, very taxing program. Very, very taxing program. They are burnt out, and nobody wants to enter that program. No, this is not part of the medical oncology curriculum. So we convinced them. One of the boys, you see, he went over there and he said कि मेरे को इसी में ही काम करना और कहीं काम ही नहीं करना, because it's so challenging and I'm going to learn so much that tomorrow I can kind of practice this. So how do we address these issues?
Madam, I think I have noted your suggestions, especially about the exposure and what is essential to create a world-class program, as well as the number of faculty required, and we'll do a wider consultation on this with all the program directors, as well as see the best practices and come out with a solution.
Okay, quickly.
Now, ये सब करने में कितना time लगेगा?
I think, madam,
because we are suffering, and we need the ventilator very urgently. We are suffering.
Madam, let me post a white paper on this regard of all the issues you have raised, and I'll call a consultation of all the programs.
Can we start a DNB program in hemato-oncology?
You apply, this is an individual problem you can discuss after the program. So let me come back to simple things. There are a couple of questions, but I'll take it in the last. The first thing is that, say for example, when I was told, when I was appearing in my MD, so the issue was that if you do not know this, you will fail. You will certainly fail. So there is always a list of do's and don'ts that if you do not know this, you will fail. Rare diseases you may not remember, though the Supreme Court judgment has come, rare diseases now need to be taught. That Kunal Shah judgment with that. But my question is, why can't I get, say, standard X-rays on the web? I'll take family medicine as an example. These are 100 X-rays on the web. If you don't identify them, you will fail. You will certainly fail. Similarly, I can have ultrasound, CT scan, MRI, standard, say 50 or 60 common diseases, say for anemia, flu, jaundice, and I put down, say 20 questions, 30 questions, that these are a must. These are a must. If you do not know this, you are bound to fail.
Right.
That what will happen with that is, then there will be uniform teaching, uniform knowledge. Uniform knowledge, people Because now everybody starts teaching them, nobody teaches anemia, nobody teaches flu, nobody teaches simple diseases, and they are the ones where you will end up into failing. Why can't DNB, of your own, with IMA or with anybody else, in every specialty, let it take 2 years, 3 years, come out with minimum knowledge, that this knowledge not knowing is a negligence. That means
Criminal.
it's criminal.
It's criminal.
It's criminal. Say for example, giving aspirin in a child is criminal. So giving dopamine IV bolus. See, I'll tell you why.
No, it is not criminal. Giving aspirin is not criminal.
In a
No,
child.
no, in a child.
In a child, I'm a pediatrician. We have used plenty of.
Under supervision. You cannot tell
Huh.
GP start using it.
Huh.
No. I'm talking about a GP.
Okay.
I'm talking about a
We
GP.
would use tons
So,
of it.
so agreed. We give it in your rheumatic fever, but then
Yeah.
under supervision, it can
Right.
cause Rey syndrome. So
Right.
a child cannot be given aspirin without supervision.
That also.
So therefore we come out with certain don'ts that if you do that is amounts to medical negligence and you will not pass. Otherwise, what happens is if I do a residency program today, say when I used to interview people for DNP entrance examination, I had a standard question. Okay, and then I would say, okay, a patient comes to you, he has a low blood pressure. How much dopamine bolus should be given? 10 ml, 5 ml, or what? Bolus is not given, is contraindicated.
Yeah.
But he doesn't know about it. So these are like things which are going to kill a person. These types of knowledge, standard education is not available. So what happens is a student coming from different places has learned differently. And I'll give you a classical example of Spring Meadows case. In a Spring Meadows case, to a child who was suffering from fever, the order was IV chlorostat. Okay? The consultant said on phone, give IV chlorostat. And then there was a debate among the sisters and the nurses, the residents. What does IV chloro means? One said it is IV chloromycetin. Another one said no, this is IV chloro means IV chloroquine. Because the place where I am trained, IV chloro means IV chloroquine. So instead of chloromycetin, the child was given IV chloroquine, ended up into a neurological fit and permanent damage. So there is no standard. There is no standard. So there has to be some standard teaching at a national level. Wherever you go, that platelet transfusion is not required unless 1, 2, 3, 4, 5. There has to be something commonly, say in flu, no fever, no flu, no breathlessness, no admission. There has to be a simple, common.
So this is the point which I referred earlier in the talk, that there is less relevance of the MBBS program. All these competencies are essentially a part of the MBBS program. If we interact with the young medical graduates of today, especially at the time when they are about to branch out into medical officer job or a DNB position or a MD position, we will find similar things. When I have been interviewing such candidates, when I was called as an expert by some recruiting agencies, I asked them a common question about the drugs, the emergency drugs, and the dosage and the mode of administration of some of the most commonly used drugs in that. Not even 10% of the candidates.
Not only question.
Yeah.
90% will fail.
And they failed because the needle gauge and whether with the increase in number, the needle bore increases or decreases. So these are the things, basic things which the nurses and paramedics would know better. And now that is why we are seeing a less respect for the doctors and a rising trend towards negligence coming in, because all these issues are practical facets of translating that rote memory knowledge.
Why do you take so much time for thesis protocol approval? I don't know who has asked it, but this is the question.
See, the mandated time for the students to submit is 90 days, and at our level also we have mandated 90 days for that turnaround time. And we routinely see only 85% of the protocols are being returned back within that 90 days period, while for others there are many queries which are generated at the assessment stage, and they get communicated back to the
Dr. Usman from Kerala, again the same question, why should we go from one state to another? Why can't all examination be held in the same state they have studied? And then he says, why should the intake of faculty be reduced in the medical colleges, especially considering the fact that we are about to implement a competency-based medical education, Dr. Ajit V.
I think Dr. Ajit's reference is towards the recent gazette which has come up reducing the faculty in some of the pre and paraclinical sciences by the Medical Council of India. And of course, there's another set of recommendation which has gone from MCI to the government regarding shift over from a traditional curriculum to the competency-based medical education system, which places the entire thrust on driving those training on the faculty. So it's a very valid concern, right?
See, my
You allow
personal-
only you allow only 3 chances for a final exam to be passed out. And
The
then-
overall chances are unlimited.
Do you have any data of
What is
how
something
many-
is that after 3 if you fail,
Yeah.
you have to give the primary again.
You have to
Why?
give your theory again.
Why?
Okay.
Because see today for me, if I am a DNB Part 1 pass,
Right.
if I am a theory pass, for me it's a degree. Because like in a Bollywood,
Yeah.
you were nominated but you have not got the award.
Right.
But still you were nominated.
Right.
As long as I have appeared in DNB, I am better than a person who has not entered into DNB.
Right.
Because I have got a 3 years of experience of even if I fail, that doesn't mean that I am a duffer or I am not better than a person who has not entered into a DNB today. So therefore, this phenomena of let them once theory pass means pass. Why should he have to give his theory again?
Well, let me find out what we can do about this issue, but I have noted the concern.
I have a suggestion.
Yes, please.
When I passed out MBBS, then we had a 1-year internship and followed by house job of 1 year house job. Then only we were allowed to enter into any post graduation, not prior to that.
Sure.
After internship, I felt I'm a uselessly third-rate doctor. I know nothing at all. The minute I did my first job, I felt satisfied, yes, I'm a doctor. After I did the second job, I felt I am somebody, I'm somebody. So when we interview the fresh medical graduate for a RMO's post, if we interview 100, I can't select even a one. I can't select even one. Because they're as useless as I was when I got some. Because internship के अंदर hardly कुछ नहीं आता. So I personally feel that house job which has been kind of हटा दिया है, that should come. मतलब 2 साल की होना चाहिए before you go for the post graduation degree, because your foundation is
You
made.
don't become a complete doctor
Yes.
without
Yeah.
house job.
Because
Yeah.
after doing my pediatrics house job, I didn't have to do my post graduation. I was a dada of the
Sure.
Kalavati. I was a
Most of
dada
the
of the
things.
Kalavati कि जिससे कुछ नहीं होता वो मेरे से करवा ले. But 6 months prior, I thought I was a useless human being. 6 महीने के अंदर इतनी जान आ जाती है इंसान के अंदर. So why omit those 6 months? Why omit those 6 months?
Agree?
Because
Also.
जो आप फेल भी हो गए एंट्रेंस एग्जाम में, तो उसके बाद आपने अगर हाउस जॉब करके प्रैक्टिस करने जा रहे हो तो जीपी तो बहुत बढ़िया बन सकते हो. आप बहुत बढ़िया जीपी बन सकते हो. आज का डॉक्टर बढ़िया जीपी नहीं बन सकता.
You are from all over the country. So English.
No, doesn't matter. Doesn't matter.
So
Okay.
I personally feel that house job should be mandatory. House job should be mandatory before any post graduation, because that
That's
sets
a
your
matter of
foundation.
policy because it was compulsory before.
Yeah.
And now they have included as a part of the training.
But they are reducing it.
I know.
They're
Well, let me
diluting
come
it.
back. Does DNB also has, apart from diploma and degrees, do they also have fellowship or certificate programs?
Certificates, no, but we do have a competency-based fellowship program.
What is that?
See, we have a postdoctoral fellowship program in 17 niche areas or subspecialty areas of the various broad disciplines. And those disciplines are like pediatrics, intensive care, pediatrics, hemato-oncology.
What is the procedure?
The
Thesis based, exam based?
No, there's an entry examination, there is centralized counseling, seat allocation is there, then the 2 years training process, followed by a certification mechanism. And
they are called as?
They are called as fellow. FNB is the qualification.
FNB.
Fellow
Is
nursing.
there hemato-oncology you have?
Yeah, pediatrics and
No,
hemato-oncology.
not pediatric, general.
No.
That also is.
So this is not that advertised because there are a lot of queries of FNB coming in the net. But then it's not well advertised.
Hemato-oncology
And then
should also
FNB
be
for that you have to attach to which hospital? Are they recognized hospital for
Yeah,
that?
these are centers of excellence, and usually tertiary and quaternary care hospitals have been recognized for various departments of such hospitals have been recognized where such training
Now,
takes place.
in terms of FNB, if a person is past FNB,
Right.
after he can join it after MBBS?
No, this is after MD.
After MD.
Yeah.
This is equivalent to
This is
Something like a DM or?
It is not equivalent.
It's like a diploma. It's like a diploma versus MD.
See,
So it's merely FMD versus DM.
Fellowship is typically a specialized training. That is the usual parlance in medical education. And since these are the areas where a full-fledged degree is not required, and that's why there is no component of thesis also, but a research component is there. And these are basically skill-based programs. Today, an MD pediatrics person or MD pediatrics consultant can easily go and practice as a pediatrics intensivist. Based on some short-term training, he can go and practice pediatric gastroenterology.
So for example, a MD medicine who wants to go for say echocardiography or say intensive care, he can go for a 2 years course, FNB, and then he can be a specialist in that. Critical care. So for a critical care, he may not have to go for a DNB or a DM.
Exactly.
He has a.
He can do this training and learn all the skills.
How many people are registered today?
See, this program inducts around 225 people every year. And we have been running this program since 2002.
Okay, the couple of questions. Respected sir, is there any plan for DNB candidates taking MD, DM, MCH exam, just like MD candidates taking DNB? What does it mean? No, they can't be. He says he can, after doing DNB, they can do MD. No, they'll have to register. That's not right. If a post-diploma candidate is doing DNB in a private hospital, if a post-diploma candidate is doing DNB in a private hospital, is it mandatory to do another year of residency for completion of course?
It depends on the size of the hospital. If the hospital is 500 bedded and it has recognized faculty, so he can refer to the TQ regulation, and in case of any further information, he can write back. We can see and guide them accordingly.
So again, tips. We have few minutes left. Give us few tips for DNB students. 1, 2, 3, 4, 5.
So first is you have joined a very good program, and keep your morale high all through the program, and it's your own hard work which will drive you to the passing line or the finishing line. Don't depend on any extraneous help or have this misbelief that the results are defined, that the results are kept at a particular level, whether it is low or high. There is nothing low or nothing high. It's a competency-based examination. As we discussed a little earlier in the talk about Safe Doctor, this is one of the very important facets and communication being given to our examiners. When there is a panel of 4 independent examiners certifying you, so the first and foremost thing which they will assess is how good you know the basics. If you don't know the basics, they'll give multiple opportunities to the candidate. Like there are around 6 cases a candidate has to undergo in an examination. Besides the 6 cases, there are bedside procedures, vivas, and some of our examinations have already been shifted to the OSCE platform, which is objectively structured clinical examination, in which a candidate will get around 30 opportunities, 30 encounters in various cases which are fragmented into, say, communication, demonstration of physical science. Then communication also 2 types, whether it is a upward communication or a downward communication, extracting information from the patient or giving some kind of counseling or instruction to the patient. Then direct observation of some bedside procedures, direct observation of practice of some skills on the simulator models. So all these are being very well structured and thought of, and then
my last question, which is my concern. People who fail, they just drop DNB. They just drop. I know so many people who says, "Humse nahi hoga." They don't want to pursue it. How to increase their morale so that once they enter into DNB, they pass. 1, 2. Many of them, they say, we have done DNB, we have got the skill. Then they try to enter into diplomas or international diplomas. All those are available. Fellowship in critical care, Australian, this and that. And then they try to do those courses so that they can call themselves as specialists. That I have not passed my DNB. They try to suffice by entering other things. How to build up the morale of the people that you will pass? If you have entered into a DNB.
No, we do not have any. As far as the exams are concerned, there is no relaxation or differential criteria. There is nothing of that sort. However, coming to the very important facet.
I say the way around. All failures, there can be a private coaching. I can see again, IMA can come out with a center only for failures. to build up their morale. We are not saying we are not making them pass, but we are increasing their morale, because they all are good students, but once they go into a depression, they don't want to face the exam. Pass to hona nahi. That feeling is there. So we can come out with a coaching of all those people who fail.
I think, sir, the therapy is different for those who are being held at the gatekeeper level, that is the theory exam, and those who are not able to qualify in the practical. So those who are being held up at the theory examination, I think we need to work with them and upgrade their knowledge. And most of the times it will be, their own fear of the curriculum or lack of coverage of the curriculum, and this professional courses which you have suggested, including these review and refresher courses, is the way ahead for pushing these candidates back into the system so that they are able to clear the theory. As far as those candidates who are failing in practical exams is concerned, we are already analyzing the data and seeing where all candidates go wrong. And with some of the professional societies like Indian Radiology and Imaging Association, Society of Critical Care, and so on, we have so many national societies. We have told them as part of their national conference they should do a residence review course. And I think IMA can also take this initiative. And a College of General Practitioners can take this initiative for family medicine candidates.
And what about foreign people are giving an exam last?
The foreign medical graduates?
Yes.
I think that that's becoming more of a social problem now. And I would like to clarify here, in the results in the foreign medical graduate examination are not that low as are being discussed or debated, because there is a backlog of 3,500 candidates in the foreign medical graduate examination. If the figure is around 3,000 to 3,500, who have not cleared the examination despite of writing the examination for more than 5 years, which is they have taken up the exam for more than 10 attempts. Now, if these candidates were part of the Indian medical education system, they would have been taken off the system. Like all the universities today working under the MCI regulation, they can't, there is a limit to the 8-year limit to the program, which means the MBBS has to be completed within a minimum of 4.5 years and a maximum of 8 years.
Otherwise,
their registration as an MBBS candidate is cancelled by the university. This is part of the regulation.
And I mean, that's not being followed here.
That's not being followed here. In fact, in the original regulation, which was notified by MCI in 2002, there were 3 years or 3 attempts to be taken up by the candidates. And the matter went to the Supreme Court, and the Honorable Supreme Court, there was a lot of deliberation. Then Supreme Court saw that this could be a diminishing factor, and they removed the upper cap on the number of this number of attempts. So now this baggage of 3,000, 3,500 candidates is adding up to the failures. If you remove this and then see the result, the result stands at around 35 to 40%.
So to end, he says, we have Dr. Kamlesh. It's a very informative telecast, and he says make your sitting arrangements modify so that you can see all the panelists together. Thank you, Kamlesh, for that. And that's all for today. We know that medical education cannot be completed in 1 hour, but we did try to introspect, we did try to answer many of the queries. And as an Indian Medical Association, we are very clear that all those who don't pass don't get disheartened. IMA is thinking of coming out with refresher courses, is thinking of coming out with coaching classes. Our objective should be that we don't only pass, but we also become a good doctor with that. And you want to add anything?
I think we have already crossed that limit.
You've already crossed that limit, and that's all for today. We thank Dr. Khanna, Dr. Bipin Batra, and Dr. Monga for joining us in this program, and all of you who have been able to make this program a success. Till next Thursday, give us we say goodbye to you. We'll come back with one more topic next time. Thank you very much.